Good morning, Chairman, panelists, and ladies and gentlemen. First, I would like to thank you, my teacher, Ajahn Rahat, who provided me the case and gave me an opportunity to be here. So let's start with the case. 27 years old Thai male, he got the motorcycle accident 6 months ago with right hip pain and deformity at his left leg without open wound, and he was sent to the nearby hospital and received the treatment. He has no injury in other part of the body and no underlying disease. From the physical examination and from the radiograph, the diagnosis was the close fracture of neck of right femur and close fracture of mid-shaft of left tibia. I have to sorry because of we can find the initial radiograph of his left leg. So look at the right hip. You see that it's a high level of power angle, about 70 degrees, with anteroposterior slope. And this was the post-operative radiograph at the first hospital. The surgeon performed the cross reduction and multiple screw fixation at the right hip. And we'll see that there's still some degree of varus malreduction of the femoral neck and slightly retroversion of the femoral neck. And look at the left tibia. The surgeon performed the lateral narrow DCP plating, and look at the distal part. I think there's not enough pressure screw, and you see that the screw at the near fracture site was penetrated through the fracture site. And there's slight anterior angulation of the tibia. So what happened next is the surgeon is following the patient, and after 3 weeks, you see that the femoral neck at right hip was collapsed, and the screw was pulled out. After 6 weeks, the same radiograph as 3 weeks, and the tibia is look like acute post-op. At 10 weeks, we'll notice that the plate at the tibia began to pull out, and the anterior angulation is increased. So the surgeon decided to transfer the patient to our hospital after he considered that the patient got the non-union of the femoral neck and tibia with the failed plating. So I think the cause of the failure of the femoral neck because of the non-anatomic reduction of the femoral necks and maybe not perfect instrumentation. And about left tibia, I think because of the mechanical failure is the main cause. So we sent for the CT scan and to confirm the non-union and found the gap all around the neck of the femur. So we decided to perform Vargas osteotomy of with the ankle bed plate at the right hip, and we make the template for the patient. We decided to make the correction about 45 degrees by cutting the neck of the femur, and we try to change the power angle from power 3 to at least power 2 or 1 if it can produce. So we put the patient in the supine position with the drape both hip and thigh legs for using the true lateral view of the C-arm. Then we remove the screw. Then we perform the osteotomy by using the KY used for the cutting guide as we template and apply the anchor blade. The fluoroscopy show we can achieve the cross reduction by closed manual. But the problem of the patient is we use the KY try to temporary fixation, but anterior part of the head is loss of bone quality, and found that almost the good bone quality is in the posterior part of the femoral head. So what we do is we have to apply the anchor blade point to the posterior part of the femoral head, while we try to maintain the anatomical alignment of the femoral neck. And after we perform, we can see that the fracture height is about 40 degrees after reduction and apply the anchor blade plate. So after the procedure, we have to test the range of motion of the hip. There's no instrument penetration or any fragment that interfere the motion of the hip joint by test the internal and external rotation. And also the left leg, we perform the fibular osteotomy and revise the plate by use the narrow LCP and apply the bone graft. So this is the post-operative radiograph. After 1 month, we'll see that it is slightly collapse of the femoral head, and the anchor blade in the lateral view is much near the cortex of the posterior part of the femoral head. At 3 months, it slightly collapsed further, but at the six month, the collapse is stopped, and we can see the callus formation at the medial calcaneus area, and the callus formation at the left tibia. So the function of the patient, he can do activity in nearly normal in daily life. And if we look at the scanogram, it may be slight shortening of the right lower limb, about 1 centimeter. So in summary, I would like to say that the most important things in femoral neck fracture is quality of reduction and stable fixation. And early detection and revision fixation of femoral neck fracture should be considered, not to delay. And at last, Vargas osteotomy is a good option in non-unit femoral neck fracture. Thank you.
Thank you very much. So, what shall we discuss? Neck or the tibia, or both?
I think more problematic on the neck. I think
okay, on the neck, because we have another case of the tibia, right? Okay, Ajahn Baccharin, please. What is your idea if you see this, the first X-ray of this post-op?
Okay, I think that sometimes wait and see the good policy, but I think that he used the X-ray like a treatment. You can see that he have many X-ray just from the beginning, the 3rd week, 6th week, and we can let's say that Dr. Suthorn already mentioned about it plan to fail, so it's not nice to wait. Another thing I think that we have to look on the opposite hip here. You can see that is not the normal angle. I think that this case is more valgus than normal. So if you plan to do any osteotomy, you have to plan for this hip also. Otherwise, you can face that it's slightly shortening. I think that you have to use this like a template for correction. For me, I think that the tibia, if in my case, I prefer to use nailing because it's more reliable, and I think that we can ream and make like a bone grafting, something like that, and more stability than the plate. But you are lucky, the fracture is healed. That's all.
Okay. Amachara, please.
Okay, I think just the start of the fracture of the femoral neck, if you see vertical shear, power 2, 3, you have to be careful. Screw will not resist shear. The only stability that you can have the screw fixed in the femoral head, but how about the lateral cortex? Just 6.5 diameter of the screw tree of this, can you provide the stability? No. So I think 2, 3, 4 years ago, we have case discussion and we have conclusion in our trauma section that vertical shear expert prefer sliding hip screw. You may add another anti-rotational screw, but in this case, multiple screw in this high power, it will fail. This is one thing. I will not discuss about valgus osteotomy because Ajahn Suthorn is one that pioneered in valgus osteotomy here in Thailand, and he may discuss more. For the tibia, I agree with Dr. Vacharin that this is bilateral fracture. So one thing is nailing may be preferred because it's a shaft gold standard, and you can put the weight on a little bit earlier, it's more stable in the axis. So even the revision, I may prefer remove the plate screw because the plating in here is biology disturbed totally. So and nail and valgus osteotomy. Ajahn Suthorn.
I think at first, if you diagnose that it's a high power, there are few options. In fact, a primary valgus osteotomy in the indication, but I believe that many of you are not familiar with doing this. So the second choice is dynamic hip screw because it's very high shearing. Sometimes you see the failure even the first week, because you can imagine the shearing with 3 screws, we will never be able to control, right? So I think the mistake is the choice of implant. For sure, you have to have a good reduction, right? So that is no question about why it failed. Considering osteotomy, I think there's a problem of the blade. It's not exactly in the lateral where it should be, okay? That luckily is still healed. In my opinion, when you have to do operation on the tibia, because it's contralateral side, the first choice for the tibia should be nail, not the plate. And I see you resect the fibula, which I don't understand why you resect the fibula. You may osteotomy fibula, but don't take the fibula and resect it out. I don't see the reason why you have to do that, right? You just oblique cut. Don't do transverse cut because you can have a gap, but you do oblique cut of fibula. So I think that is what I may do different.
Okay, because I just clarify some points because I think this is a good case that wait and see is very bad because when I go to fix the femoral bone head was lost. That's why the position of the blade is quite off because when I put in the middle, it's very unstable. It's no bone inside. So that's why I have to change the position a little bit because I think she walking like this for 6 months and the screw is toggling inside. So that's why the plate, I knew intra-op that is a little bit off, but I think it's the most stable position that I can get. So I think if he came earlier, it will be a lot easier for the osteotomy. Okay.
So just add small. If you see early failure of femoral neck, never ever wait. I never see in my life that it will heal. Because at a short segment, it will fail. I have a case that wait 14 months. I don't know why. So I want to emphasize, never ever wait and see in the femoral neck fracture when you fix and it start to see that it's failed. Okay. It's only get worse.
Okay. And last comment about the tibia. My first choice was nailing, but the patient was social security. He cannot reimburse the nail, so I have
social insurance.
Yeah, social ประกันสังคมครับอาจารย์ so I cannot reimburse the nail. So that's why I end up with the plate. And I cut the fibula to use as a bone graft. So, so okay, let's.
It's more painful.
Yes. Okay, so thank you very much, Dr. Pornsak, for your
Okay.
presentation.
Thank you very much. So we go for the next